As we are short of time, I'll request the next talk by Professor Karaca from Istanbul. She is the head of the Department of Medical Oncology at Turkey, and she'll be speaking on immunotherapy in metastatic lung cancer as well as in melanoma.
Hello all. Actually, I'm from Izmir, Ege University Faculty of Medicine, where Professor Zilali is also from. And thank you for the invitation and thank you for the great introduction. Today, I'm going to speak on the systemic management of brain metastases. And actually, we have some words to say as medical oncologists, beginning from the 2010, because before that, we didn't have any effective drugs to control the brain mets, but now we do. So as a result of improvement in the systemic cancer therapy, and higher resolution and greater frequency of brain imaging, brain metastasis incidence is increasing in the last years. Within all type of cancers, brain mets are the most common in lung, breast, and melanoma patients. So the first cancer I'm going to talk about is melanoma because it represents about 12% of all patients with brain mets. Nowadays, targeted therapy and more immune checkpoint inhibitors are used successfully to treat advanced melanoma. That's what we know. Combi-MB, which is the combination of dabrafenib trametinib, is the first randomized clinical trial to show efficacy of targeted therapy in melanoma brain mets. The most common type of BRAF mutation is BRAF V600E in melanoma. However, this study also included very rare mutations like BRAF V600D, K, and R mutations. This study demonstrated the clinical utility of BRAF MEK inhibitors in which patients who had BRAF mutation, and it's about 40% of the all advanced melanoma patients with asymptomatic or symptomatic brain mets, and it had an intracranial overall response rate of 44%. Unfortunately, leptomeningeal metastasis was excluded from the study, so this clinical phenomenon stands as a huge clinical challenge for us. So when we look at the response patterns of the COMBI-MB trial, there were 4 cohorts. The cohort A are the asymptomatic patients who have not received any local therapy before. Cohort B patients, asymptomatic brain mets, again, who had received some local therapy, mainly radiotherapy. Cohort C are the patients with rare BRAF mutations, BRAF DAK, DKR, and cohort D are the ones who are symptomatic with rare mutations. So what we see here, the best overall intracranial response that we see is 44%, and there were some CRs actually in cohort A and cohort B, and of course in cohort C and cohort D are less in response. So, but what's more important is what is the intracranial duration of response in this trial? It is not very high in regarding to mounts. It's around 46 mounts approximately. So that's far less than what we see with the immune checkpoint inhibitors. So as a result, COMBI-MB trial clearly demonstrated us there is an intracranial activity of dabrafenib plus trametinib in melanoma patients. However, from a practical point of view, cerebral disease is not really controlled in nearly half of the patients, which still represent an unmet clinical need. And we should also keep in mind leptomeningeal metastasis is not really included in the study, and most complete responses were achieved in patients with 1 to 2 brain metastases, which are also effectively managed with surgery or stereotactic radiosurgery, as the previous speaker had already pointed out. So later on, new clinical trials with immune checkpoint inhibitors were done in the era. And this had some very flashing results, actually. First trials were using immune checkpoint inhibitors as monotherapy, mainly anti-PD-1s as monotherapy, whereas the recent clinical trials were using immune checkpoint combinations. So when we look at the long-term results of the Checkmate 2 or 0 trial in patients with active melanoma brain mets treated with the combination nivolumab plus ipilimumab, that's mainly an anti-PD-1 plus anti-CTLA-4. When we look at the results in asymptomatic patients, which were high in number, there were around 33 over 30% of complete responses in the intracranial area, so which is quite astonishing, actually. When we look at the symptomatic patients, of course, it's low in number, only 18 patients, but it's very striking for us to see there were also some complete responses with the EP-nivo combination in this arm again. But what is more important here is when we look at the duration of response, this matters, this differs from the ones that we see in the COMBI-MB trial. As you see, the ongoing responders are the ones, patients with the objective response, and it's over 85%. So this is very important. The ones who have already responded to the combination immune checkpoint inhibitor do live longer and do not really show up with any more brain mets. So then came the ABC study and changed a lot, actually. This was a real game changer for us. This was a study by Georgina Long from the Australia Cancer Center. Melanoma brain metastasis over 5 millimeter up to 4 centimeter, up to 5 metastases were allowed. No previous anti-CTLA-4, anti-PD-1, anti-PD-L1 agents, no immune checkpoint, this means. But previous BRAF/MEK is allowed. ECOG performance status might be up to 2, which is very rare actually in clinical trials. No serious autoimmune disease, no corticosteroids. So it's a 1-to-1 ratio up to 51%. The cohort 8 included no prior local brain radiotherapy, asymptomatic patients. There were 35 patients, nivolumab plus ipilimumab. When we are talking about here, ipi is the high dose ipi. And cohort B included no prior local brain radiotherapy, asymptomatic patients, and they received only nivolumab, anti-PD-1 monotherapy alone. Then they added another cohort, cohort C. This is actually a group of patients with a very bad prognostic features, previously treated or symptomatic or leptomeningeal spread with MRI progression, and these were treated with nivolumab alone, and there were 16 patients in this arm. So primary endpoint was the intracranial response, but secondary endpoint, overall response rate, FS, and overall survival. When we look at the ABC patient characteristics, it's a well-balanced actually trial, and mostly the patients were in good health shape, ECOG performance status either 0 or 1. Around 55% of them BRAF mutated, but when we look at the bad prognostic arm, which is the arm C, there were 81% of them with BRAF mutation, because this is what we know from melanoma. People with BRAF mutant melanoma had worse prognosis. And targetable brain mets over four brain mets were around 40% in the cohort A, 20% in cohort B, and over 50% in cohort C. So prior BRAF MEK inhibitor usage were around 25% in cohort A and B, but when we look at the cohort C, it's 75%, so heavily pretreated, we can say. So when we look at the intracranial RST response, so we can easily see that the cohort A, asymptomatic patients who received Nivo-EP, no local brain radiotherapy, had an intracranial response of 51% and complete response of 26% actually. When we look at the Nivo arm alone, we see that it's much less effective. And when we look at the C arm with leptomeningeal mets, symptomatic, and who had received already local radiotherapy, so we can see that 6%, around 6%, there is only in one patient intracranial response, and that's negligible. That's what I can say. So in the drug treatment naive patients, this means the patients who have not received any treatment before, no BRAF MEK inhibitor, nothing. So when we look at these results, then the cohort A, we can see that the results have already increased regarding the intracranial response and also complete response. The complete response is 30% in the Nivo-EP arm, and it's 16% in the nivolumab arm. Progression-free survival is very striking here because, as I said before, when you are applying EP-Nivo combination for patients with brain mets, the one who have already responded do live longer. You can see these are the mounts. It's very interesting because we are talking about melanoma brain mets. So we can see that after 60 mounts, around 50%, 46% of the patients who had brain mets are still living. These are the patients treated with ipilimumab, nivolumab. But when we look at the other cohorts, of course, when we treat the patients with monotherapy, only 15% of them are living, and the ones who had already symptomatic brain mets, leptomeningeal mets, the bad prognostic factors, only 6% of them are alive at the 5-year. So when we look at the drug treatment naive arm, the numbers are a little bit better for them, but it's around 50% again. So we can definitely say that using EP-Nivo and ipilimumab in the higher dose for these type of patients is the new standard of care for melanoma. Any subsequent therapy after intracranial progression, of course, most of them stereotactic radiotherapy, local therapy. Some of them had surgery, of course. And when we look at the systemic therapy, mostly the BRAF MEK was chosen if they didn't receive it before. But of course, chemotherapy was also applied, about 11% of them. Yeah, overall survival we can also see from here. So when we look at the conclusions, nivolumab, ipilimumab has enduring activity in patients with untreated asymptomatic melanoma brain metastasis, no prior local therapy or BRAF MEK inhibitors. These results are similar to the studies of ipilimumab and nivolumab in patients without active brain metastasis. Long-term survivors had a numerically higher proportion of patients with lower burden of extracranial metastasis as expected, normal LH and ECOG 0 at baseline, and of course, no NIV toxicity was observed with the long-term follow-up. We now know these drugs very well, and we have been using it over 10 years now. Although when we come to breast cancer, this was the melanoma story. When we come to the breast cancer, all breast cancer subtypes are at risk of developing brain mets. But of course, the incidence is the highest for patients with triple-negative breast cancer. It's around 50%, and HER2-positive disease, it's around 30%. For HER2-positive patients, lapatinib and tucatinib, these are two anti-HER2 drugs working intracellularly, have the modest intracranial activity as monotherapy. It's around 10%. But their intracranial activity increases when they are used in combination with capecitabine. Capecitabine is the oral form of 5-FU, and it has a high penetrance through the blood-brain barrier. So the combination with the combination treatment, the response goes up to 30%. But HER2CLIMB trial searched for the answer of the addition of tucatinib to trastuzumab capecitabine combination in patients with brain mets. Trastuzumab is the anti-HER2 drug, but it acts as a surface on the surface. Tucatinib works in intracellularly, actually. So addition to tucatinib, according to the HER2CLIMB study, addition to tucatinib to trastuzumab capecitabine improved overall survival as compared to the placebo group in this group of patients. It's around 25 months versus 19 months in over 600 patients. But more recently, there were some newer drugs on the shelf, new kids on the block, to treat these types of brain mets in HER2 positive breast cancer. And antibody drug conjugates have shown really great efficacy in controlling brain mets in HER2 positive breast cancer. So Destiny-01 is a study which has evaluated trastuzumab deruxtecan. This is an antibody drug conjugate in patients with heavily pretreated, around 2 to 3 cycles of treatment before, lines of treatment before, with HER2 positive disease. And among these, there was a subgroup of 24 patients who were treated for brain mets. In this group, overall response rate, intracranial response rate was 59%, and median progression-free survival was 18 months. So we can now say that trastuzumab deruxtecan is the new standard of care for this group, especially for patients who are asymptomatic. For triple-negative breast cancer, actually nothing really much happened on the systemic treatment side concerning brain mets in particular. So local treatment options should be the first to choose in this group. Of course, for neoadjuvant treatment, adding pembrolizumab, which is an anti-PD-1 treatment, is a real game changer when we're talking about locally advanced triple-negative breast cancer. But unfortunately, immune checkpoint inhibitors didn't show great efficacy in controlling brain mets in triple-negative breast cancer group. So let's pass to the lung cancer, but let's pass to the lung cancer, which is ALK positive, because ALK positive breast cancer, lung cancer is a special subgroup. ALK positive lung cancer patients represents about 5% of the all non-small cell lung cancer, but in approximately 40, sometimes in 50% of those who present with brain mets. So new generation ALK inhibitors, ceritinib and more likely lorlatinib, have demonstrated intracranial response rate of up to 50% in this group of patients who have already progressed on chemotherapy or first generation drugs like crizotinib. So we can now say that for patients with ALK positive lung cancer with brain mets, lorlatinib or ceritinib, lorlatinib we have in Turkey actually, lorlatinib is the new standard of care for this group of patients. What about for EGFR positive non-small cell lung cancer? EGFR positivity is around 15%, and mainly women who are non-smokers. Currently, osimertinib, which is a TKI inhibitor again, is recommended for those with asymptomatic brain mets And actually, increasing the dose of osimertinib from 80 milligrams to 160 milligrams might also control some leptomeningeal metastasis, which is a very important and a clinical challenging topic for us. So we may escalate the dose in some of those patients who have EGFR positive metastatic non-small cell lung cancer. Last but not least, it's highly recommended that patients with brain mets who are candidates for systemic therapy that have demonstrated intracranial efficacy should be discussed in a multidisciplinary tumor board to determine the optimal integration and sequencing of these therapies. Not everybody needs surgery, not everybody needs radiotherapy now. I have a very short case. Sorry, this is in Turkish, but I'm going to just translate it. This is a 46-year-old male patient which had a melanoma on his right forearm, and the pathology revealed as this superficial spreading melanoma, breast lobe over 5 millimeter, ulceration positive, and mitosis were there. Actually, no sentinel lymph node invasion was there, and he was on the follow-up, and 3 years later, he developed both in a left axillary lymph node and together 2 mets in the brain, one 10 millimeter, one 7 millimeter, and the patient was asymptomatic. The mass in the left axillary was very hard and very fixated. We did a true-cut biopsy and was shown melanoma metastasis with BRAF V600E mutation. And of course, we started, according to the ABC trial, we started with the EP high dose and Nivo, 1 milligram per kg. And after 3 cycles, he couldn't afford the drug anymore, but we did a cranial MRI and we saw that, of course, there was a complete remission of the lesions. You can easily see it here. Now he's doing very well after 12 years of treatment with a immune checkpoint inhibitor combination. So this is what I would say. Thank you for your patience. And I'm ready for the questions, actually.
Yeah, thank you, Professor Karaca. Then for highlighting that immunotherapy, once immunotherapy is very popular, maybe neurosurgeons and radiation oncologists are not needed because everything can be treated with immunotherapy.
Not really. We do still consult patients with radiation oncologists and neurosurgeons, of course.
Yeah, thank you. Because we have a session to follow, we have to cut down the questions. I'll request Professor Jalali to give a concluding remark and start the next session. Professor Jalali.
Hi. Yeah, it was a great seminar, actually. I thank all the speakers for their very valuable contributions. Also, our friend Burçak from Izmir did a very well talk. I think